Everyone. Now we are going to have the second educational webinar of the Young Neurosurgical Nurses Forum of ACNN, and respected Professor Yoko Kato, patron of ACNN, Matron E, Honorable Chair, respected speakers, moderators, and chairpersons. I gladly welcome you all to this webinar. And in the absence of Professor Yoko Kato, I welcome Professor Kenichi Haraguchi to do the opening remarks. Up to you, Prof.
Nice to meet you, everyone. I'm Kenichi Haraguchi. I'm working with Dr. Kato from this April, and we are very sorry that Dr. Kato has emergency work today, so I see it's absent. So on behalf of Dr. Kato, I make some greeting. So so nice to meet you. So we start our second ACNN YNN webinar, and so please start the first session, Dr. Shani.
Yeah. Okay, thank you, Prof. We'll be having a session on endovascular management for AVM by Dr. Jayadevan, followed by a session on nurses' responsibility during and before and after of neuro imaging. And we'll be having a session on the educational preparation for Japanese nurse practitioners. And we'll move on to the webinar. Today, today we plan to have 3 different sessions. We have different session chairs for each session. We have eminent neurosurgeon who is specialized in cerebrovascular surgery with us, Dr. Jayadevan. He is additional professor of neurosurgery in Ms.Chisato Institute for Medical Science and Technology. Actually, he's an eminent neurosurgeon specialized in endovascular surgery as well as computational flow dynamics and fluid structures of cerebral aneurysms. And sir had done more than 5 fellowships in UK, Japan, and in India. And he had incorporated many of the technical advances into the surgery, especially management of intracranial aneurysms, AVMs, and myelin diseases. In fact, he is one of the adjunct faculty of our Indian Institute of Technology in Madras. I gladly welcome you to chair the session on endovascular management for AVM. Off to you, sir.
Thank you very much, Dr. Shani, for the lovely introduction, as well as for having me here to moderate this session. And it's my proud pleasure and privilege to do the proceedings of this session, because the speaker for this session is Dr. Jayadevan, who is a very close friend of mine and my colleague at Ms.Chisato Institute for Medical Science and Technology. Dr. Jayadevan is highly specialized in cerebrovascular endovascular procedures, and he manages a lot of aneurysms and arteriovenous malformations and dural AV fistulas through the endovascular techniques. And he has a lot of publications to his credit, as well as 6 patents in the development of medical devices. He has accomplished himself by winning a lot of awards, and he has also been academically very strong, and he has been the former associate editor of Journal of Clinical and Interventional Radiology, and he's also the section editor of the textbook of radiology. So today, I think Dr. Jayadevan will be discussing on the endovascular aspects of management of arteriovenous malformations. And day by day, the technology is advancing so fast that it is very difficult to keep pace of these things. And I'm very happy that ACNN has taken this initiative to further advance this training to nursing personnel as well, who will be the backbone of assistance to the procedures in both in endovascular as well as cerebrovascular neurosurgery. So I welcome Dr. Jayadevan to this session, and over to you, Dr. Jayadevan, for your talk.
Am I audible?
Yes, sir.
Yes.
Okay. Good evening to you all. So thank you very much for the introduction, Jayan and Shani, and Professor Kenichi and Yi. So I will be directly going into the presentation. So basically, this endovascular management of AVM. I will make it as simple as possible to understand everyone the basic thing regarding the angiography and the imaging and how to go about the diagnosis and how to decide regarding the treatment, especially regarding the endovascular. So I'll just switch off my video for better streaming. So I'll share my slides now. Hope you can see the slides in full screen, right?
Yes,
Yes.
Dr. Jayadevan,
Oh,
proceed.
Okay.
I request the others to keep their microphones in the mute so that we will not have any restrictions during the session. Thank you.
Okay. So the brain AVM, as you know, that they are abnormal tangular vessels, which is usually seen in any part of the brain. So when we see an image, so you can see that there will be an abnormal conglomeration of the vessels within the brain. So in an angiogram, you will be able to see as an abnormal vasculature in an angiography also. So when you see that what actually the brain is, the brain AVM is, when you see that there is a artery and the vein in between, there will be a capillary network. That is a normal anatomy. But in an AVM, this capillary part will be replaced by abnormal connection vessels, which are rather larger than the usual capillaries. So this in an AVM, this is a usual scenario where you don't have a capillary which is bridging the artery and vein. There will be a direct shunting between the artery and the vein. That usually happens in AVM. So the perioperatively, you will be seeing on the brain surface, there will be multiple tangular vessel, and the DSA, you will be able to see the subnormal vessels in the DSA. So the precise etiology of this AVM is not clear actually, but it's usually considered as a developmental one and usually appear between age of 4th and 8th week of gestational intrauterine life. But sometimes there is a controversy in that also this in neonates or in intrauterine imaging, sometimes it is not seen and later only it is seen. So, but in general, it is considered as a developmental lesion. Location-wise, convexity, the brain convexity is the commonest one. The next is deeper part. So this is the brain convexity in the MRI. You can see a triangular lesion, which is in the brain convexity. And this is a deeper, which is the deeper gray matter like a basal ganglia and adjacent ventricle. So this is convexity and the deeper are the commonest location. The other locations are subcortical. They are very small in percentage in number. So when you say convexity, it can involve into the deeper part also. Sometimes from the convexity, it can come into the deeper part also. It involves the subarachnoid space, gyrus, sulci, adjacent ventricle, contiguous involvement can happen. So the pathology and its presentations are related to the angiographic or the architecture of the brain AVM. So when you say in the brain AVM, mainly it has three components like an artery, multiple arteries which is feeding the AVM. There is a nidus part, and then there is a draining venous part. The presentations could be a hemorrhage, focal neurological deficit, or seizures, or headache. So first we talk about the hemorrhage. A feeding artery. So this is a feeding artery. If there is an aneurysm in the distal part of the feeding artery, or within the nidus, this feeding artery, there is an aneurysm, this can produce bleeding. Or sometimes a relatively large venous sac on the venous side, that also can produce a bleeding. Sometimes around the nidus, there will be multiple tangular vessels may develop, that is abnormal angiogenesis. That also, because of the high flow, it can also produce bleeding. So these all situations will produce usually the bleeding. And the focal neurological deficit is usually produced by high flow. See, say for example, if very high flow is going into the feeding artery, adjacent area, there will be steal will happen, and this area will go in for ischemia or infarction. So because of that, as a resultant, focal neurological deficit can happen. Sometimes an AVM is arising from a functional area like a visual area or a motor area, sensory area, language area. That also can produce a focal neurological deficit. Okay. And seizures are usually produced by the large venous sacs. Usually, if suppose a large dilated venous sacs which is pulsating on the surface, or is a large size of the AVM, that also produces associated gliotic changes, also produces seizures. Okay. And headache is usually produced by either by large size of the AVM or a large venous sac, or sometimes from the outside dura coverage, this AVM may get fed through the dural branches, that is an external carotid branch. Because of the engorgement of the dura, that also will produce headache. So these are how the different symptomatology are coming and how they are presenting. So hemorrhage, focal neurological deficit, and seizures and headache. These are the commonest ways of presentation. So when you see an angiogram or imaging features, there are a lot of features which can predict these symptoms, especially hemorrhage. When AVM arising from the deeper location, or it is fed by small perforating arteries, or it is there is an intranidal aneurysm, proliferative angiopathy, that means around the AVM there is multiple tangular vessels is proliferating, that is proliferative angiopathy. That also, there is a large fistula, that is artery is going and opening into a large vein, so a large AV fistula. Then deep venous drainage, only one which is draining vein for the AVM. Then large venous ectasia, large venous circulation, so ECS supply. These are the one which predict chances of higher rate of hemorrhage. And especially those who are lesser age, younger age, less than 40 years, male sex, and during pregnancy, and those who are having hypertension also tend to have more chance of hemorrhage. Now, this is actually the angio architecture analysis of AVM. I'm not going into the complete details, so you have to analyze the feeding artery, nidus, draining vein, and finally you have to grade the AVM, depends upon all these features. So I'm not going into all these features. So first we will see how do we image. So basically we need a CT or MRI. Generally we use a MRI. And along with that, one angiogram also, MR angiogram. So MRI plus plain MRI and MR angiogram. Contrast is usually not required. So this is a usual imaging sequence we generally use. Usually if the patient presents with a bleed or a suspicion of the bleed, generally we go for CT. Otherwise, generally the MRI and MR angiogram is the usual sequence. And MRI, any kind of MR angiography sequence like a TOF MR angiography, phase contrast, silence MR angiography, 4D flow, all MRI sequence you can go ahead. This is a MRI which shows a bleed in the parieto-occipital area, and there's an abnormal tangular vessel in the parieto-occipital area with a small amount of bleed here. So this is a MRI evaluation of a AVM. And this is a TOF image, the MR angiogram, which shows the PCA artery, and there is a feeding artery aneurysm. There is an abnormal tangular vessels in the occipital area involving the visual cortex also. So this is a 3D MR angiogram which shows a large AVM in the occipital area with a feeding artery aneurysm. The same one in the axial. This is in the axial plane, and this is in this. This one is in the sagittal, and this is in the axial plane. So you can see that very well. You can see the entire arterial network and the parenchymal involvement in MRI. So the next, the definitive imaging method is actually DSA. What we call it is a gold standard, or the definitive complete angio architecture. We can very well see with the DSA, and DSA is required in all cases for understanding. So this is a DSA. As you all know that we will be injecting iodinated contrast into internal carotid artery and vertebral artery, and the contrast goes into the artery and through the feeding artery, and this is a nidus, and then from the nidus, and this is the draining vein goes into the dural sinuses. So these are the feeding artery. Here you can see the two feeding arteries are there and only one draining vein. And this is a very compact nidus aneurysm, compact nidus AVM with the two feeding arteries and one draining vein. Okay, so this is a DSA. Actually, we call it as a 2D DSA. Only two planes we are seeing. So this is a 2D DSA where you can see the feeding artery, nidus, and there is an aneurysm. And there is a faintly you are seeing the draining vein here. But this is a 3D DSA where you can very well see the much better angioarchitecture, intranidal aneurysm, small other arteries which is also supplying. That also we can see small venous drainage pathways. You can see all better finer detail of the angioarchitecture you can see from a 3D rotational angiogram. So 3D rotational angiogram is always required for complete angiographic analysis of brain area. So why? Because see, this is a 2D angiogram. Within this conglomerate vessels inside, we cannot identify if any intranidal aneurysm. But 3D rotational angiography will show an intranidal aneurysm. So that is another important thing. Another thing is the venous stenosis. Because of the high flow over a period of time, the draining vein go in for stenosis. So that is a predisposing situation for producing a bleed. So the venous stenosis also better seen with the 3D rotational angiogram. And actually venous circulation, if large venous circulation, even with the 2D we can see, but it is a very small location, and which compartment of the AVM these venous circulations are there, that will be better seen with the 2D, 3D angiogram. Another important thing is here is a 2D DSA is showing no AVM here. This patient presented with the bleed in the deep white matter. But in the 3D DSA, it shows a definite small micro AVM in the 3D angiogram. So that is another importance of a 3D angiogram. So 3D angiogram is always required when we go for imaging of a brain AVM. So it is the intranidal aneurysm, the fistulous components, and also draining vein stenosis. All these we can see relatively well in 3D compared to 2D angiograms. Now we have imaged the AVM with either with the CT or MRI, generally with the MRA and MRI, and after that an angiogram, digital subtraction angiogram we do. And after that we will go in for a staging of this AVM. There are multiple staging methods are there, but generally the commonly used, widely used staging method is personal Martin grade. Okay, where we have three components: size of the AVM taken at the maximum diameter, location of the AVM, in which part of the brain it is involved, then venous drainage, in which vein is draining. So these three components we will be taking, and then score will be given to each component, and accordingly we will get a score. And if the maximum diameter is less than 3, score is 1. And if the maximum diameter of the nidus, actually the nidus is 3 to 6, the score is 2. And if it is more than 6, its score is 3. And the location of the AVM. If the AVM is located in eloquent area, that is any functional area, that is in this area, like a sensory motor, language, visual, thalamus, hypothalamus, internal capsule, brainstem, cerebral peduncle, and these cerebellar nucleus, they are eloquent area, then it will get a 1 score. If it is a non-eloquent involvement, 0 score. The venous drainage, if it is a deep venous drainage, 1, superficial drainage, 0. So then we add entire score, and you can get a score from 1 to 5. So as the score increases, the management of the AVM is also difficult, and also management related to complication is also difficult. Whether it is a surgical management or endovascular management, as the personal Martin grade goes from 1 to 5, the complications related to the management and also the management per se also very difficult. Now, which all situation we go in for a treatment for a brain AVM? Usually hemorrhage. If the AVM is blood, usually it will go for a treatment is indicated. In an unruptured AVM, so these are the situations where intractable epilepsy, where you even without optimal anti-epileptic medication, patient is throwing recurrent seizures. So intractable epilepsy is not responding to optimal medical treatment. Then progressive neurological deficit, hydrocephalus, severe headache, disabling blue or tinnitus. So these are the main symptom or indications for treatment of brain AVM. Now, how to treat it? Generally, surgery is the mainstay for AVM treatment. So microvascular surgery is the mainstay for the treatment. So the grade of SM grade 1, SM means Purcell Martin grade 1 and 2 are mainly microsurgery. Grade 3 means they are little larger AVM. Okay, so because of that, surgery may not be completely possible because it is a little larger one. It may require an endovascular or radiotherapy before surgery to reduce the size. I'll come to that. Then SM, the Purcell Martin grade 4 and 5, they are quite large AVMs and usually complete surgical, endovascular or radiotherapy management is very difficult. They usually go for a palliative or conservative management. And if the patient is coming with a bleed, only targeted treatment, embolization or other treatment only will be done because they are very large AVM and occupying a significant volume of the brain parenchyma. So complete management of this grade SM grade 4 and 5 are little difficult. So that is about the management. So mainly it is surgery. So grade 1 and 2 is microsurgery. 3 is usually surgery. Sometimes it requires other modality support also like endovascular or radiotherapy. And SM grade and 4 is mainly targeted management only or a conservative follow-up management. Now, when it comes to embolization, which all situation we go for embolization? So embolization, when you see that the complete curative embolization is possible only in a very small number of cases, like 20 to 50% of the cases. And that also possible only with the grade SM grade 1 and 2. That is curative embolization is possible only with the grade 1 and 2. And grade 4 and 5, that is the largest size embolization. Usually they go for largest size AVM, they go for palliative embolization, wherever it is blood, wherever there is a high flow fistula which is causing symptom, where is causing a very dilated venous sac which is causing obstructive hydrocephalus or venous hypertension, that only we will block or embolize. Embolization means we will be blocking that vasculature with some materials. In grade 3, we generally go for adjunctive embolization. That means grade 3 embolization in AVMs, we do embolization to facilitate either for surgery or for radiotherapy. So grade 3 AVMs are quite large AVMs. Usually they will be more than 3 centimeters in size, where radiotherapy usually may not be possible. Then we reduce the size below 3. And if the AVM is larger, we will reduce the AVM size, especially the deeper part, the superficial part later it can be surgically removed. So grade 3 usually is a combination of the treatment is usually done, and in that embolization is done as an adjunctive method. And grade 1 and 2, probably most of the situation we can do curative embolization. And 4 and 5, usually it is a palliative targeted embolization. We will never go for a curative embolization or for an adjunctive embolization. So this is the same thing which I have mentioned. Now we see that how we are embolizing this lesion. So generally we use liquid embolic agents. So liquid embolic agents, these embolic agents are we injecting into the involved, through the involved artery into the nidus. They are liquid-based embolic material which will block the artery and the feeding artery and the nidus. So these are two categories are there. One is an NBC, N-butyl cyanoacrylate with lipidol. I'll tell you what it is. And then is another three material, that is Scut, onyx, and minox. There is 18 number and 12 numbers. These are the viscosity of this material. Scut, onyx, and minox. They contain EVOH as the primary material. EVOH is ethylene vinyl alcohol, which is the primary material which is blocking the artery, on which DMS or dimethyl sulfoxide will be used as a diluent. And this is not through the X-ray, we cannot see this material, into which we add a tantalum powder. So because of that, this will get a radio opacity. So under fluoroscopy, under X-ray visualization, we can inject. So all these materials, Scut, onyx, and minox, contain EVOH, DMSO, and tantalum powder. So this is the main material we use for a AVM treatment. But in some situation, when the flow is very high, very high flow AVM, or when there is a feeding artery or a intranidal aneurysm to be blocked initially, so we use NBCA, the N-butyl cyanoacrylate. So this is a N-butyl cyanoacrylate, which is also not visible when you inject under X-ray fluoroscopy. For visibility, we injected lipidol, that is an iodinated poppy seed oil. So that also, we will mix at a particular ratio, then we will inject. So these are the usual liquid embolic agent we generally use. There is another one more material is there, that is called fill, which is actually a different material, which is actually a based on a iodine-based material, which can also be used for AV embolization. It's not widely available. That material name is fill. Now, we use a very small microcatheter for delivering this material. So this is a one such material, microcatheter. So the inner diameter of the material is around 300 micron. So this is a microcatheter. This Apollo microcatheter, other similar microcatheters, Marathon and Sony. So you can see that, so we will be injecting the material through the distal tip. As it goes into the nidus, and it will percolate in the entire nidus, and then it tends to come back. And it will cover the artery also, so the delivering catheter also. After some day, you will not be able to take out the catheter from the vasculature. So this is a detachable catheter where when you pull this catheter will detach at this location, though this much part of the catheter will remain in the vasculature, and only this part will come out. So that will help in prolonged more volume injection. So this is a detachable microcatheter generally used for AV embolization. So these two are the Apollo and Sonic are detachable. Marathon is a non-detachable microcatheter. So this is AVM, an example of AVM. So this is a pericallosal area. This is an AVM with an intranidal aneurysm. Now, if you see, this is an injection of NBC. If you see this area, you can see that there is slowly the NBCA cast will be going into the nidus. Slowly now it will start coming. So you can see that the cast is percolating into the nidus through the microcatheter and entering into the nidus. Now it is reflexing back. So we will quickly pull back because the glue NBCA will entrap the catheter more than the EVOH based material. So once it reflects back, you have to quickly pull it back. So this is after the injection of the NBCA. You can see the NBCA cast in the nidus and the artery. Okay. And this is a pre-procedure AVM, and this is a post-procedure. The AVM nidus is completely obliterated. So next is curative embolization regarding, this is a parieto-occipital AVM, left side with a bleed. You can see the bleed and the parieto-occipital. This is an MRI shows a bleed within the parieto-occipital area. And this is an angiogram which shows an AVM nidus in the parieto-occipital area supplied by the posterior cerebral artery. So this is other side is you can see that post embolization the nidus is completely gone after embolization. So this is the pre-embolization nidus. In the post-embolization, there is no nidus. And this is, you can see the cast formed by the onyx. That EVOist material, slowly we have injected and percolated into the nidus. So it has taken the shape of the nidus. So this is a cast of the onyx. This is adjunctive embolization. Adjunctive embolization, as I have already mentioned, when you want to reduce the size of the AVM to facilitate the surgery or facilitate the radiotherapy. So this is you can see there is a very large convexity AVM, very large one. So surgical resection is also very deeper, and the superficial part it is difficult, and also it is more than 3 centimeter in size, which is not available for radiotherapy also. So this is we have embolized with a liquid embolic agent like a skewed, and then this much part we have embolized. Now only very small amount is remaining. This can be either tackled by surgery or by radiotherapy. Now the palliative embolization. Palliative embolization we do when the AVM is very large, very extensive, especially grade SM grade 4 and 5. And generally we don't go for a AVM complete treatment. The associated symptom producing lesion only we will be tracking. So this here, you can see there is a feeding artery aneurysm which has blood, and that we have completely occluded by that parent vessel occlusion. So completely occluded that artery. This is another large feeding artery aneurysm from the pica artery, and this AVM. This AVM anyway we are not planning to embolize. So only the aneurysm part we have completely coiled, and the AVM is remaining. So this is, since it is a very large aneurysm, there is a very high chance of rupture at any time because of the high flow. So that we have coiled with a complete obliteration, and the AVM we have not tested, and the patient is not very much symptomatic for the AVM. And this is another patient where the patient is after embolization, partial embolization, still the patient's raised intracranial feature is not coming down. So you can see that bilateral transverse sinus is showing stenosis because of the high flow AVM related stenosis, and which is treated by placing a stent through the transverse sinus on both sides, which is giving adequate flow. So that will help in the better drainage of the remaining AVM, and also will reduce the intracranial raised intracranial hypertension also. So in general, the AVM embolization is basically curative nature is only possible in a very less number of cases, maybe around 20 to 50%. 50% is actually a very large number. Practically, it is around 20 to 25% only. It will be possible because of the various factors. And most of the situation, embolization is an adjunctive treatment to facilitate surgery or to facilitate radiotherapy, or in some situation, very high-grade AVM to reduce the symptom like a headache, or because of the ECA feeders, dural feeders, we will just block the dural feeders. Or if the high-grade AVM presenting with the hydrocephalus because of the venous sac compression, we will obliterate that part of the AVM only. Or a high-grade AVM presenting with the focal neurological deficit due to the large steel effect, that steel compartment only we will obliterate. So these are the scenarios where generally we go ahead with the embolization in brain AVM. So imaging part-wise, brain AVM, MRA or MRI is a usual imaging modality we use, and DSA is the gold standard and always require a 3D DSA for complete angio-architecture analysis. And embolization is mostly used as an adjunctive treatment or for the support of surgery or RT. And in very less number of cases, like 20 to 50% of the case, only complete curative embolization is possible. Thank you.
Thank you, Dr. Jayadevan, for a very lucid presentation. You covered almost all aspects of management of AVMs, the staging system as well, and also how we treat the aneurysms associated with the AVM. And also thank you for going through all the embolic materials and the paraphernalia required for embolization. Now the floor is open for discussion. Any questions are welcome. And also check our chat box. I think no questions are there in the. Anybody has any questions? You may raise the queries. Looks like your presentation has been extra clear, Dr. Jayadevan. So I don't see any questions.
Thank you very much.
All right, with this, we end this talk.
Raised and risky.
Hello?
Yeah. Yeah, hello. Hello.
Yes, is there a question?
Yeah. Thank you. Thank you for the presentation, so clear. And Prof. Jayadevan give me another set how to understand about AVM. I'm a nurse and I have a question about the complication. Is there any possibility complication, maybe in intracranial complication followed by surgery or maybe after radiology intervention based on your experience, and it might be developed to diffuse hypoperfusion also or not? Thank you.
Yeah, complication wise, of course, it does carry significant amount of complication. When we see that in endovascular treatment scenario, AVM is the one difficult pathology to be treated endovascularly. The complication is really unpredictable. Sometimes a simple AVM, sometimes suddenly it bleeds. So the main complication in the procedure is bleeding, either because of the device-related bleeding or the aneurysm bleeds, or because of the aneurysm related to the AVM, or because of the there is a pressure variation which is happening inside the AVM. So that is one thing. Another one is inadvertent embolization of other normal feeding arteries. So that is another problem. So the bleeding is the most dreadful complication. That is especially when it happens during the procedure, it will be torrential bleeding because patient will be on heparin. So that is the thing. So the ischemic complications are rather less. The major complication is usually bleeding.
Okay, thank you, Prof. Thank you.
Okay, thank you.
Are there any more questions?
Can I ask, please?
Yes, please.
So in Japan, we cannot use detachable catheter, microcatheter, like Apollo Sonic. So I'm very interested in them, and so we are waiting for the devices.
Yeah.
In the presented cases, you showed you used the marathon catheter. So I think if we can use the detachable microcatheter, there is no reason to use the marathon because it's dangerous to throughout. So what's the reason why you use the marathon catheter in spite of you can use the detachable catheter?
Yeah, that's a very good question actually. Generally, we use a detachable catheter when we use EVOist based material like onyx, skewed, or fill, or this kind of material, where we will be injecting for a prolonged period of 1 hour or 1.5 hours, where the reflex will be more. And the marathon we generally use when we use NBCA, where we will inject quickly and we will pull the catheter immediately. We won't allow any reflex actually. Even though it reflex comes, immediately we will pull it. So when we are planning to use NBCA, like N-butyl cyanoacrylate, in that situation only we use a marathon. In all other situations, like wherever we use EVOist based material, we use a detachable microcatheter. So the case I'm shown is actually NBCA, which I have used. So you can see that immediately when the reflex started, I have pulled the catheter back.
Thank you very much.
Thank you.
Are there any more questions? Okay. I think with this, we'll conclude this talk and discussions. Thank you, Dr. Jayadevan, for a wonderful and lucid talk on the management of arteriovenous malformations. Back to Dr. Shani for taking on the proceedings further.
Thank
Or
you.
Ms. Mai. Thank you.
Thank you, Jayadevan sir, and thank you, Dr. Jayadevan. I think Professor Maso would like to ask any questions and add more points on that.
Thank you very much for a great talk, and impressed by your very understandable, good presentation. Because I am a clinical neurologist, especially critical care neurologist, I'd like to ask you about the medical aspects of AVM. Which do you think that are about the severity of the AVM and the complications of endovascular surgery between superficial or cortical or deep cortical?
The complication, which one is more will produce more complication, whether it is superficial or deep? That is the question. Okay, so the endovascular wise, just like surgery, the deep is the one which is difficult to treat actually. Mostly they will be fed by multiple tiny perforating arteries, and which we will not be able to actually navigate it with a microcatheter. So the difficult one is especially the deep, especially basal ganglia AVM, which is AVM in the ventricles, or which is in the brainstem. So these are the one which is actually difficult. Just like surgery, endovascular also difficult. So the only way which we can do most of the times, we have to go with the transvenous, because the arterial access will not be there. So there we have to go transvenous route, and then only we can embolize. So compared to the superficial, the difficulty is more with the deep, and also complication related to the procedure also more with the deep lesions.
Thank you very much, and it's a very good comment. However, I'd like to ask you about the severity of the manifestations, because it may be easier to handle the superficial region. However, it can also cause the cognitive impairment, like dementia, and also seizure of convulsive or non-convulsive, and both. So therefore, it necessarily does not necessarily depend on the severe difficulties of the operation, but also the potent complications. So that's what I mean, and I asked you.
Okay.
Can I ask one question, sir?
Mm-hmm.
Dr. Jayadevan,
Okay.
if there is any risk for thrombus development before the procedure or during the management period, or do you advise heparin or any other anticoagulants for this patient?
Usually during the procedure only, during the procedure, we will be giving heparin. As any neuro intervention, we give a heparin. But after the procedure, heparin is not indicated, because after the procedure, there is a tendency for development of the bleeding in all these patients. There is a chance. So because of that, post-procedure, we generally don't give a heparin. But if there any symptomatic venous thrombosis is happening after embolization, in that situation only we give anticoagulants. Otherwise, we generally don't give. So always we reverse the heparin after the embolization procedure is over. And if there is a large dilated veins or multiple veins or a venous sac, and it may go in for thrombosis after the embolization, and if produces symptomatic venous thrombosis, then only we go for a post-procedure anticoagulation. Otherwise, we will not give.
So what are some of the nursing points or while caring a patient immediately after the procedure in ICU?
That is one important thing. One important thing is BP management. That BP management is a main issue for all these AVM. Especially immediately after the procedure, we generally don't. We usually do the procedure through the femoral route, and there will be a femoral sheath will be there. And femoral sheath care is important. Suppose if you are not immediately removing the sheath, once the heparin is reversed, we can remove the sheath. And if there is any hematoma developing at the groin, we have to see that. Another thing is that post-procedure, we have to keep a very stringent BP. Not very low, at least if it is a large fistula, especially we have blocked a large AVM, large fistula, generally we keep the BP, mean arterial BP, 20 to 30% of the initial BP for at least for 24 hours. For that, we use SNP, sodium nitroprusside or NTG, any of these IV antihypertensives, minimum for 24 hours to reduce the BP. So sometimes because these AVMs bleed because of the hyperperfusion syndrome. There is a hyperperfusion syndrome because of the high blood flow from the occluded vessel, which will go into a already patent very small vessel, which are on under vasomotor paralysis. All these large volume blood will be delivered into a small blood vessel which is on vasomotor paralysis that will easily go in for rupture. Because of that, we generally keep the patient on hypotensives after the procedure, mainly 24 hours, usually 20 to 30% of mean arterial BP. So that is the main thing we usually do. Then patients generally other neurological status, we have to see whether patient is developing any bleeding symptoms. Accordingly, if any significant bleeding, sometimes we may have to take a patient for surgical evacuation.
Thank you, sir.
Yeah, thank you, Dr. Jayadevan, for those enlightening remarks. And also the possible need to keep the sheath for a prolonged period. Could you discuss something in that realm also, whether it would be required, or how long do you retain the sheath after the procedure?
Yeah, generally we don't keep it because after the AVM, generally we reverse a heparin immediately because there is fear of bleeding. We reverse a heparin with a protamine, and then immediately after we remove the sheath. But if we expect some post-procedure, some complication, or the patient has developed on-table bleeding or anything, or you are expecting any hyperperfusion issue or anything, in that situation only we will keep for another 6 hours. Then after that we will remove it. That is not a usual situation. Usual situation, we remove the sheath on table itself.
Fine.
If may I ask?
Are there any more? Yeah, Dr. Raja is here.
Yeah, hi.
Sorry, I didn't notice you again.
It's okay. First of all, let me thank Prof. Jayadevan for this excellent lecture, and we learned a lot. Regarding my question is like in a case of AVM which has bled, not so severely, but fair enough it can be managed conservatively. How long do you wait to start for an endovascular treatment? And next is obviously when there is a complex AVM and you have a rockstar colleague BJS with you. So how often do you discuss regarding whether it can be managed either surgically or endovascularly?
Yeah, we generally on almost all AV cases we discuss together. Then only we take a decision regarding which other embolization or surgery to be done or not. And regarding the question regarding acute ruptured AVM, whether immediate management to be done. So what we do is we generally in acute ruptured AVM, what we do is we do a CT angiogram if any large feeding artery aneurysm or a large intranodal aneurysm which has blood, which requires an early management. So that situation we do for whether it is surgery or it is endovascular, we go ahead. Otherwise, to understand the complete angiographic anatomy, it is better to resolve the hematoma a little bit so that we can wait maybe 4 to 6 weeks and after that do a angiogram. Because initially we are doing a CT angiogram, we have got some idea about the angiographic anatomy. And after that we do after 4 to 6 weeks, we do a complete DSA with including 3D. Then we do the procedure. But initial angio, CT angiogram shows any definite evidence of a large fistulous component, large venous sac which is ruptured, or a feeding artery which is ruptured, or intranodal aneurysm which is ruptured. Definitely, we will not wait for 6 weeks. We will immediately manage.
Thank you very much.
Also, one more concept in that one is that once the AVM has ruptured, sometimes we see very small AVMs shattering, and the rupture would have caused the nidus of the AVM itself to shatter. And once the hematoma is resolved, we will be seeing the AVM nidus in bits and pieces on the walls of the hematoma. So that is one situation we have often seen in blood AVMs. And maybe Jayadevan can comment on whether you can actually treat those AVMs endovascularly or whether they can they need surgical removal.
Yeah, that is what is actually Jayadevan was mentioning, a splitting of the nidus into two compartments or partially into compartments. So when this compartmentalization comes, actually this is a quite difficult scenario endovascularly, because they will have a different artery and different draining vein. So in a single stage, you will not be able to tackle in almost all situations. That is some other thing we generally prefer to wait for some more time for getting an angiogram so that the hematoma resolves, the compartmentalization comes down. So in immediate situation, the compartmentalization will be more. You may not be able to tackle all the compartment or at least 2 or 3 compartments together in a single stage. So this is a difficult situation regarding endovascular management. That will be surgery will be better in that situation.
Yeah, sometimes we go in for a hematoma evacuation in the acute setting, and then we sometimes do not test the AVM in that surgery. And once the patient has been stabilized, we go in for an angiogram at a later stage and understand the angioarchitecture better and then take a decision. Okay. So, Dr. Shani, shall we conclude this, or do you have any more questions? Anybody from the audience? I don't see any questions in the chat box either. Okay, I think we can proceed to the next session.
So Christine has a reason. Hello, Christine.
Hello, Prof.
Yeah.
Yeah, I'm Christine from Indonesia. I'm interested about the patient after surgery AVM. And as a nurse, have you significant monitoring for the pain monitoring after surgery? Because we have instruction and we have management for after surgery must minimize for the rebleeding, for example. Yeah, and for the pain, because if the patient have the high pain, high score for the pain, can increase the ICP, like this. Yeah, thank you, Prof.
For endovascular management, I think there will not be much pain, except at the puncture site, and that's usually taken care of well. But for open surgery, pain is an issue, and sometimes we have to give good enough analgesia to control the blood pressure, mainly more than the raised intracranial pressure. Because in the post-surgical scenario, we'll be more interested in maintaining euvolemic status and also to control the blood pressure to a large extent to prevent any bleeding from the bed of the surgical resection. Okay. Any further questions?
Yeah, one more. Actually, Christian was reminding about the pain management, how pain because of embolizing a blood vessel.
I didn't hear the question. There was some interruption.
Yeah, I'm asking regarding post-procedural pain, any headache or
usually post-embolization, the embolization related pain usually won't be there. And if the pain is there, for us, it is a ominous sign that it is a patient has developed some bleeding. So now, otherwise, usually post-embolization, the pain is not very common with an AVM, but it's for a dural AV fistula, pain will be there because we are embolizing dural branches. Intracranial AVM, pain won't be there, but if the post-embolization patient is experiencing significant pain, that is an indication that the patient might be developing mild amount of bleeding or a venous sinus thrombosis.
Thank you, sir. Now, Dr. Jan can conclude the session so that we can move on to the next. You're muted, sir.
Sorry, yeah. Okay, thank you, Dr. Jayadevan, for a wonderful session on the embolization of endovascular management of arteriovenous malformations. A good discussion followed, and many of the queries have been answered quite clearly. And thank you, Dr. Shani, for this opportunity as well. Over to you for further proceedings.
Okay, thank you.
Thank you. Mai will be continuing the later part of the webinar.
Okay, now let's start the second session. We have invited two speakers today. So now I would like to introduce our session chair for the nursing session, Ms. Miyuki Hirosue. She is a chief nurse practitioner at the Fujita Health University Hospital, Japan. With her extensive experience in emergency NP and chief NPs, she will guide us through today's insightful discussions. Please welcome Ms. Hirosue.
Thank you. Good evening, everyone. My name is Miyuki Hirose from Japan. I am a chief nurse practitioner from Fujita Health University Hospital, Sept. I will be moderating the second half of the program. And let's begin with our first speaker of the session, Mr.Beniard Mendrofa. The presentation is entitled Peri Procedural Nursing Consideration for Neuro Imaging. Mr. Mendrofa, are ready? The screen is yours.
So, good evening, everyone. My name is Beniard Mendrofa. So, I will talk about procedural nursing consideration of neuro imaging. So, let me share screen first.
Okay, Benny.
Okay, is everyone can see
Yes, we can.
the screen? Okay. Neuroimaging, including modalities like MRI, CT scans, and angiography, plays a crucial role in the diagnosis and management of neurological conditions. These advanced imaging techniques provide detailed insights into brain and spinal cord structures, helping healthcare providers make informed decisions regarding patient care. The role of nurses is important in ensuring patient safety and quality outcomes during neuroimaging procedure. As a nurse, our role in the neuroimaging process is vital. The purpose of this presentation is to highlight the essential nursing considerations and interventions that ensures patient safety and optimize outcomes during neuroimaging procedure. By understanding the key aspect of procedural preparations, intraprocedural monitoring, and post-procedural care, nurses can effectively contribute to the successful execution of these complex imaging studies, ultimately improving patient care and diagnostic accuracy. So, pre-procedural consists of three sections: pre-procedural, intra-procedural, and post-procedural considerations. Agreed protocols and an integrated care pathway should be established so that the nurse is able to assess the patient's suitability for treatment as an outpatient or day cases or inpatient avoiding unnecessary and sometimes prolonged use of beds, thus optimizing resources and potentially avoiding delays in patient treatments. During pre-assessment, the nurse instigated routine investigation and subsequently reviews and acts on the result according to agreed protocols and pathway. For example, ensuring that patient receive intravenous hydration before contrast injection where necessary. Obtain document informed consent, ensuring the patient understands the procedure, its purpose, risk, and benefits. Other document such as admission referral letter, laboratory test, and then last MRI or CT exam, if any, and insurance payment confirmations. So all of these patient preparations is to make all the process is efficient. So it's improve our service to our patients. Patient assessment. So don't forget, as a nurse, we have to make sure and guarantee the international patient safety goals. There are 6 keys that we've always concerned about, like identify patient correctly, and the 6 key aspects. And then the nurses have to do medical history review, like claustrophobia if the patients have this phobia, and then identify any known allergies, especially to contrast media or medications. Check for contraindication to neuro imaging, such as implanted devices, pacemaker, or severe renal impairment. In case patient using pacemaker, inform the radiographer to contact the vendor to activate MRI mode about 3 days before. Patient also need to take laboratory tests before CT or MRI with contrast, especially kidney function like ureum, creatinine, and EGFR. Anticoagulant. Review the use of blood thinners, which might need to be adjusted before certain procedure. Hyperthyroid. So patient with hyperthyroid have avoided the contrast because it can trigger the thyroid storm, because iodinated contrast agents contains iodine, which can significantly increase the amount of iodine available in the body. It can worsening the hyperthyroidism too. Current medications like diabetic medications is have to be in our considerations too. If patient needs to fasting, yeah, especially when patient needs sedation. Patient preparations for fasting. If patients need the sedations or general anesthesia, fasting, the patient must do the fasting. Fasting guidelines can vary slightly depending on the hospital or clinical protocols. So it's important to follow specific instructions provided by the healthcare facility. So these guidelines I'll show is in my hospital, like MRI contrast, 4 to 6 hours total fasting, and then CT contrast. If the patient go to CT contrast, 2 hours solid food. So the patient can have the clear liquids, but the patient must avoid the caffeine because the caffeine may increase heart rate and make the vasoconstriction of the vessels. If the infants with breast milk is 4 hours before the examination. Stop diabetic regimen for the patient with diabetic regimen. And then In the emergency procedure, where fasting isn't feasible, the medical team may take additional precaution to mitigate risk. Patient education. Communicate with patients step-by-step procedure and what to expect during imaging. The nurse needs to possess knowledge of all relevant procedure to be able to inform the patient about the procedure and answer any question the patient may have. Provide a clear explanation of the procedure, including what the patient will experience, such as lion still, noise from the MRI, sensation, like discuss potential sensations such as warmth from contrast media or the loud noises associated with MRI. And then inform the patient the expected length of the procedure and the importance of remaining still for accurate imaging. Monitoring in intraprocedural it's of vital. The monitoring consists of vital signs like blood pressure, heart rate, and oxygen SpO2. Monitor SpO2 levels to ensure adequate oxygenation, especially if sedation is involved. And then a level of consciousness and neurological status. Regularly assess LOC to detect any signs of neurological deterioration, especially in patients with pre-existing conditions like stroke or head injury. And then make sure to comfort the patient, like the positioning for comfort and imaging quality. Ensure the patient is comfortably positioned on the scanner table to prevent discomfort and to present to prevent discomfort during prolonged imaging. Proper positioning optimize imaging quality. And then we set up the immobilization devices such as cushions, straps, or foam supports to maintain the patient position and minimize movement during the scans. And then anxiety management, we are nurse to provide reassurance and use breathing exercise or any relaxation technique to help reduce patient anxiety. Sedations, if necessary, administer sedative as prescribed to help the patient remains calm and still during the procedure, particularly for the claustrophobic or highly anxious patient. And then safety precaution, like MRI safety, metal object implants. Screen patient truly for any metal implants such as a pacemaker, cochlear implants, aneurysm clips, and ensure they are removed if possible. Because MRI strong magnetic field can interfere with or cause harm if metal objects are present. Hearing protection or the others. Contrast media reactions such as allergy reactions, nephrotoxicity. So this is our MRI and CT scan in Siloam in Indonesia. There are so many equipment like earphone, straps, and the other. So this is our MRI patient safety and care. Before the patient going through the MRI, make sure the patients or the family complete this checklist. Yeah. MRI patient safety and care. Ancillary equipment safety criteria must meet one of the following, like manufacturer safety declarations, equipment is tested and confirmed safe by the maker, FDA approval, approved by the Food and Drug Administration of MRI use, and previous testing demonstrated safety in prior testing scenario. Metallic implants considerations, torque risk. Metallic implants can experience significant torque in magnetic field, especially if not properly anchored. Impact of metal type ferrous metal. Strong magnetic fields can cause notable deflection, increase the risk of injury or equipment malfunction. Non-ferrous metal tend to accumulate heat due to RF absorption, which can be hazardous within the MRI environment. There are so many equipment that patient such as aneurysm clip. The aneurysm clip itu clip material largely determines its safety within the MRI's environment. Ferromagnetic clip, like those made from certain stainless steel types, pose serious risk and are contraindicated. Non-ferromagnetic or weakly ferromagnetic clip, such as specific alloy or titanium, are generally safe. MRI with aneurysm clip should only proceed after confirming the clip type of non-ferrous, and then such as hemostatic vascular clips, typically made from non-ferromagnetic materials too, so it's safe. And then intravascular coil, filters, and stents. Some intravascular devices are ferromagnetic but can become embedded in vessel walls over time, reducing dislodgement risk. MRI is usually safe for patients with these devices after a sufficient post-implantation period. Orthopedic implantations show no magnetic field deflections, like a plate and screw we usually use to close the bone in the cranial. Usually, it's no magnetic field deflection. Additionally, hitting the magnetic and RF field exposure is unlikely, making most MRI procedures safe for our patient with this implant. So these are implant that we encountered in neuro imaging. And then prevention of infection, decontamination, hospital-acquired infections. According to CDC, general principle to contain infections and to be applied by all healthcare professionals are based on this following: hand hygiene, follow the 5-moment and 6-step procedural of hand hygiene, and then personal protective equipment if some cases of infectious materials, cough, sneeze, etiquette, isolation awareness, environmental cleanness, ensure disinfection and sterilization of materials and surroundings, and then textile handling handle and dispose of laundry as per facility policies, safe injection practice, adhere to the one needle, one syringe, and one use. It's a common international rule. And then sharp safety, follow protocol to ensure the safe handling of sharps. This is the post-procedural considerations. The early recognition of adverse reaction to contrast media is a part of the remit of the interventional radiology nurse. Following the procedure, patient may require intensive nursing supervision in the observation area of the care ward. Some patients will also need to be reviewed on the ward following the procedure. The clinical status in the day case patient needs to be assessed before discharge. Monitoring like vital signs and neurological checks. Patient recovery, don't forget to educate patient to drink much water because the patient is undergo the contrast agent. Monitoring for contrast-related complications such as nephropathy, and then discharge, post-imaging care, signs and symptoms to report, such as headaches, dizziness. So the conclusions, the role of nursing in neuroimaging procedure is critical to ensuring patient safety, comfort, and the accuracy of diagnostic outcomes. From through pre-procedural preparation and vigilant intraprocedural monitoring to careful post-procedural care. Nurses are at the forefront of managing the complexities that these advanced imaging techniques entail. By adhering to the best practice in patient assessment, preparation, and care, nurses not only help prevent complication but also enhance the overall quality of healthcare delivery. The expertise and attention to detail that nurses bring to the neuroimaging process are indispensable in achieving successful patient-centered outcomes. Thank you.
Mr. Mendrofa, thank you for your great presentation. Does anyone have a comment or questions? I don't see any.
Just an excellent presentation. Actually, he had covered all the aspect of nursing consideration before and after the procedure. I think we can invite the commentators, Prof. Maso, to add more points. Yes.
Yeah. Hello. Hello, Miss Miyuki. Is my voice audible?
Yes, I can hear you.
Okay. Okay, congratulations, Mr. Benny, my colleague from Indonesia. I'm Resti from National Brain Center Hospital. So the lecture already refers us about our role during peri-procedural for the patient undergoing neuroimaging. And I would like to greet for Miss Professor Kato. Good evening, Prof. Kato. Thank you for joining. Okay, in our hospital, in National Brain Center Hospital in Jakarta, we have one nurses dedicated in each shift. So all the procedures, sometimes neuroimaging needs a contrast, and also maybe some patient should be assisted by nurses during sedation for MRI. So maybe based on your experience and maybe you can give your point of view about what is the most important aspect about the nurse competencies in maybe neuroimaging or radiographic procedures, Mr. Benny.
Thank you for the question, Mr. Rizky Rahman. I think the most important thing to be nursing who understand about the sedations. So the first thing is get some training for the to be a nurse, anesthesiologist nurse. So you can understand, you have the knowledge, the basic knowledge of the patients, the basic the medications, the anatomy, the physiology. So it's all the basic that we need to be understand and to be able to assist our anesthesiologist. It's the basic knowledge, and then I think as the fresh graduate, it's hard for us to assist the doctors directly in the first time or second time. Maybe the policy of our hospital regulate that observations first, and then you can you can go first with your seniors, and then teaching directly from your seniors, and after all of that process, and that you can build your experience, and then you can assist the anesthesiologist in the examination and your examinations. I think that's the important thing.
Okay, thank you, Mr. Beniard. So I think the nurses in the radiology and working in a radio imaging, I think not only should capable or maybe full skilled in technical, but also I think the nursing process also she or he should gain, and maybe about a special of to treat the special condition like patient with sedation, and also how to monitoring during procedure. I think it also the other aspect that should be gained by nurses who work in neuro imaging. I'm agree with you. Thank you very much. Thank you, Mr. Bain.
You're welcome.
Thank you. Dr. Haraguchi, do you have any comments or questions? You're on mute.
Okay, sorry. Thank you for your very nice presentation, Mr. Benny. So I want to ask about pre-procedure consideration. That is very important for to perform good treatment for us, neuroendovascular surgeon. And in your presentation, you explained that the pre-procedural condition of the patient, such as renal function and thyroid disease and metal implants. But of course, we endovascular surgeon check them for every patient, but sometimes we forget to check. So it's very helpful. So in your hospital, these conditions are checked by the new nurse practitioner. Is that the systematical rule in your hospital?
I'm sorry, what the terms again, Professor?
So I mean, is all the patients' conditions are checked by nurse practitioner in your hospital?
Checked by the nurse practitioner before the examination?
Not by doctors, by nurse practitioner.
Nurse practitioners. Depends on the cases, patient case. If the patient case on sedations or the contrast, likely we get the patient into inpatient department. So when inpatient department, so the nurses must check the patient before the procedure. even if the patient comes from the daycare department, the cases, so it's also checked by the nurse practitioner, because the patients have to daycare when checked by the nurse practitioner in that ward.
So, sorry, what does daycare mean?
Daycare is when the patient comes and lives on the same day.
Same day.
So it's like it's like a 6 or 8 or 12 hours in the hospital. So the patient comes, have beds, and then go home in the same day. So we divide inpatient, outpatient, and also daycare in Indonesia, in my hospitals.
Okay.
So in some cases, well, we can divide the patients need the daycare or the inpatient, or come from the outpatients. Depends on the cases.
Thank you.
You're welcome, Prof.
Thank you for your discussion. Yeah, does anyone have any comments or questions? And can I ask you a quick question? We also use that kind of checklist for before MRI for all the patients. And do you use any pamphlets or information sheets to educate patients?
I'm sorry, I don't get the question. Could you please repeat it again?
Yeah, you pointed patient education is very important before the
Yes.
MRI or any contrast media imaging. Then, do you use any pamphlet or information sheet to educate patients?
Yeah.
Okay, thank you. Are you talking?
So we have the pamphlet in our hospital before the patient go through the examinations, and then we have the checklist, the procedure checklist of what the patient needs, and what the patient go through of the examination. And then we have also, if the patient need the fasting, we have the board of fasting, and then pamphlet, yeah, to educate the patient.
Now, if nobody has the questions, let's move on to the next. Our next speaker is Ms.Chisato from Fuseya Health University Hospital. She is a nurse practitioner and is currently in training. Her presentation is entitled Japanese Nurse Practitioner Education. Ms. Fuseya, you may begin.
Yes, hi everyone. Hi, good evening. So today I'm going to talk about the Japanese nurse practitioner education at Fuseya Health University Hospital. So again, I'm a nurse practitioner in Japan. So I'm going to share my presentation. Can you see my presentation?
Yes.
But maybe, how about this? Can you see my presentation now?
Yes, yes, we can.
Okay, thank you. Thank you. So NP education in Japan has a different process each hospital. So today I'm going to give a presentation about the NP education at Fujita Health University Hospital. So before I talk about the education, let me introduce Japanese nurse practitioner system. Most of Japanese nurse practitioners belong to the Japanese Organization of Nurse Practitioner Faculties called JONPF. The purpose of JONPF is to contribute to people's health. It also provides nurse practitioners education, practices, and research. And in 2008, the training system for NPs started as a master's course in graduate school. In 2009, Japanese Society of Nurse Practitioners called JSNP was established. The following year, in 2010, the Japanese government decided to create a nurse practitioner system similar to the US. In fact, doctors' overwork has always been a major issue in the Japanese medical field. Moreover, with the shrinking birth rate and the number of young and middle-aged people in the workforce will decrease over time, leaving a smaller segment of the population to provide for the elderly population, which is rapidly growing in number. In 2015, JSNP changed its name to the Japanese Organization of Nurse Practitioner Faculties for incorporation, and the primary regulation for nurses has changed for the NP system. According to JONPF, NPs require some competencies. First, comprehensive health assessment. Second, management of basic medical procedure. Third, skilled nursing practice. Fourth, skilled nursing management. Fifth, collaboration and working in medical team. Sixth, utilizing and developing medical health and welfare systems. Lastly, ethical decision-making. So NP operate with hospital and medical practices in much same capacity as a doctor. So I'm going to talk about the differences between US nurse practitioners and Japanese nurse practitioners. In the case of the American, they assess patient, order and interpret diagnostic tests, make diagnoses, and initiate and manage treatment plans, including prescribing medications. On the other hand, in the case of Japanese nurse practitioners, they can do the specific medical interventions that Ministry of Health, Labor and Welfare permits. And also they can perform non-specific intervention under doctor's supervision. There are 18 universities which are authorized by the JONPF to provide NP training throughout Japan. Fujita Health University Hospital is striving to function similarly as the NP system practiced in the US. According to JONPF, there are 880 NPs registered with the JONPF. So I'm going to discuss the NP education at Fujita Health University Hospital, where I work. So it has 4 hospitals. In total, 37 NPs work at 3 of them. 12 NPs are in the training program as trainees. 25 NPs belong to each major department. So this is the topic for today. First, I'm going to talk about how to become a nurse practitioner in Japan. Here are steps to become a nurse practitioner in Japan. First, you have to be a registered nurse. To become a registered nurse, you have to take a nursing program at university, community college, or professional training college. After finishing the program, you have to take the registered nurse board exam. Then you need to gain an experience of no less than 5 years. Second, you need to finish a master's course for 2 years. Third, you have to pass the exam for NP license. So it's not the national license, it's certified by the JONPF. Second, I'm going to explain the education program for NPs at Fujita Health University Hospital. The education program for NP takes 2 years. NPs have 38 specific medical interventions and non-specific medical interventions. The 38 interventions specified and grouped into 21 categories cannot be performed by registered nurses. NPs don't only need skills for those interventions, but also discernment of whether they should do them or not. So one of the main specific intervention is inserting a PICC. PICC is the peripherally inserted central venous catheter. NPs in a training program insert a PICC under supervising instructor. So between 2013 and 2023, a total of 8,077 PICs were inserted into patients at Fujita Health University Hospital, of which 6,055 PICs were done by NPs and 2,022 PICs by physicians. The fact shows that NPs inserted PICC approximately triple as many PICCs as physicians did during this period. So there are some non-specific medical interventions. For example, NPs assist surgeons during operations. In laparoscopy, NPs maneuver the camera. They learn and train from surgeons, and NPs suture surgical wound in the end of the operations. In addition to that, NPs are not only giving assistance, but they also give orders patient based on the assessment under doctor's supervision. Let me introduce one of the trainees' schedule in the first year. They go through clinical training in some department at Fujita Health University Hospital. During the first year of the training program, NPs belong to some department for 1 to 2 months. The main aim in the first year is for them to gain a wide range of knowledge through clinical practice. This is a schedule in the second year. During their second year of training program, they must have a training in different departments for 3 to 4 months. Looking forward to the following year, they are going to develop their assessment skills, master medical techniques, and management skills. And on their third year, they have to decide which department they want to work for. Let me give you a quick overview about neurological surgery department. So picture shows that the spinal surgery and the vascular surgery, endoscopic hematoma evacuation for chronic subdural hematoma, removing subcutaneous drains, preparing for endovascular devices. So this picture shows that NPs are able to do some procedures instead of the doctors. So in addition to that, let's talk about the future outlook on NPS. In Japan, they are not well known yet, so I hope to the recognition of them. Furthermore, I hope there will be an increase in their number. As a result, NPS will play a significant role in patient care. It will lead to opening more opportunities for them and letting them practice their profession on a more comprehensive scale. Thank you for your attention.
Thank you for your presentation. Now I would like to invite commentators here. First, Dr. Kenichi Haraguchi, please give us any comments.
Thank you, Ms. Fuseya. I have just came to Fujita University in the last April, and the most surprising thing I experienced here is NP's skill. It's very so great, and they are very skillful, and so far, yeah, it's very helpful every day. Thanks for you. We don't have to insert PICC, or we don't have to receive the call from the ward. Thank you very much. And I have one question about your slide. So you presented about the difference of NP between that of US and Japan. And in the United States, the NP can open the clinic or subscribe the medicines or everything. So then what is the difference between doctors and nurses in the United States? Do you know?
Oh, thank you for your question. So actually, I'm not sure about what the differences between doctors and nurse practitioner in the US. So I just know that differences between nurse practitioners in Japan and US nurse practitioners. So next time when I see you, I'm gonna talk about what the differences between doctors and nurse practitioner in the US. I'm gonna study about it.
Thank you very much. Yeah, I'm looking for seeing you.
Okay, thank you. Me too. Thank you.
Thank you. In my knowledge, in the US, first, the professor, the emergency medicine used to work in the US, and he worked with the nurse practitioner in the medical center. He said almost the same, but sometimes nurse practitioners more familiar with the patient and more popular in the clinic. The patients have the cheaper Medicaid or care or prescribe the medicines. Then some people, mainly the not so rich people, choose the nurse practitioner clinic. In nurse practitioner, they still have they need to be the supervision from the physicians if they need. That's what I know. Then now, Dr. Nagayama, Would you give us any comments?
Yeah, thank you very much for a great talk. And no need to say the NP is critically important for not only for the nurses and the physicians, but also medical staffs and the patient. And I'd like to ask you one question about the role, kind of subspecialty of NP. For example, in the United States, there is a lot of nurse research nurse. However, in Japan, just in NP, is it do you think that it is needed to subclassify or have the subspecialty of, for example, neurology NP or neurosurgery NP or research NP? Yeah, just considering the just this is a question just considering from the United States. Yeah.
Thank you for your asking, Dr. Nagayama Sensei. Thank you. So I think we should have subspecialties. For example, neurological surgery, NPS, and neurological surgery. NP have another specialties. For example, anesthesiology, anesthesiology technique. So if NP had subspecialty, we can do more medical treatment under doctor's supervision. For example, in the neurological surgery department, if NP can do anesthesia, so during the operation, NP can do anesthesia to patient. I think it's so useful and helpful to doctors. I think so. In my opinion, yes, this is so important to have subspecialty. But now there are 880 NPs in Japan, so we don't have many NPs. Yes, that's why we have to spread our job or our skills to to Japan.
Yeah, completely agree with you. Yeah, just too small now.
Yes.
Anyway, in the future, it may be the kind of the purpose of the objectives, maybe in the future. But anyway,
Yes.
at this time point, I respect your university to reading this field. Thank you very much.
Yes, thank you so much.
Thank you. And next, Mr. Snowan, risky recommend. Would you please give us any comments?
Okay, thank you. Congratulations, great impression about nurse practitioners program in Japan. And I think I invite to the Japanese because of Indonesia, not clearly state about the role of nursing, the role of nurses in the master degree level. So actually in Indonesia, we have a 3 level of nursing professions, diplomas, and also Bachelor of Nursing. Maybe it's same with registered nurse, and we have also nurse specialist. So the nurse specialist is they should pursue their study in a master degree, but a little bit different in Japan. We don't have any national regulation about the role or what can nurse perform as a nurse specialist, so still under supervision with the doctor. So when the nurse specialists perform medical treatment and so on, they should be get a mandatory or delegation letter from the director of the hospital. So the regulation is the competence is still in a local regulation in a hospital. So I think I have a question to Mrs. Chisato. In in your opinion, what is the big impact? What is the impact of the nurse practitioners in a hospital or maybe in a national healthcare as well? Maybe you can share so we can follow the way the organization, professional organization, to develop the independency of the nursing specialist. Maybe you can share, Mr. Chisato.
Thank you for your question. So, Mr. Risky.
Risky,
Thank you. Risky. I'm sorry,
Yeah.
Risky. Mr. Risky. So, in my opinion, in Japan, doctors overwork is always major issue in the medical field. Yes. So main point is so NPs can help doctors tasks. So we can we can help doctors. That's the main point to be a nurse practitioners. Yes, and also we NPS can treat patient more compared to yes. Yes, I think the most variable thing is to help the doctors.
Okay. Great. Okay. One question I'm interested about the program. Our hospital is also the big hospital referral in neurology, and also for the next future we will be a center of education, and I hope and we hope our hospital will be a center of education for neuroscience nurses. So we have national neuroscience nurses organizations, and we develop it, but I think it is our dream to bring the neuroscience nursing as a specialties, just like nurse practitioners in Japan. And about the program, I'd like to ask to you about how the final examination perform in the end of the program. So the examination performed by government body or by the collegium or maybe national nursing organization, how the final exam perform in that program, Mrs. Chisato.
You mean in the graduate school, NP course in graduate school? Okay. In graduate school, we learn major subject, for example, physical assessment, about medication and physical assessment. So, and like physicians and surgeon studies. So we NP yes, and moreover, we in NP student practice some department such as neurological surgery department, gastrointestinal surgery department, and so on. And during the practice, student can learn medical techniques and medical knowledge throughout practice. So yes, after graduating, university, graduate school, we have own NP education program like my slide. So we have a lot of practices in medical field.
So after finishing the program,
Yeah,
did
after
you take
finishing the program.
national examination, to get the license? How to get the license certification of and yeah,
after graduating the master's course. Okay. We take the nursing. We take nurse practitioners kind of a board exam, not board, but examination. We take the NP examination.
Yeah.
And after that, if we pass the exam, we can be nurse practitioners.
Okay, I get the point. Okay, the last question maybe is there any chance for us Indonesian nurses going abroad to Japan, to Japan to join in this program, and how do we pursue this program? Maybe we can learn more from you, Mrs. Chisato. So we are so exciting and interesting to pursue our nurses going abroad to get a nurse practitioner. Maybe we can talk later. Thank you, Mrs. Chisato.
Yes, I hope so. Thank you.
Thank you. Thank you.
Thank you for your good comments from Indonesia, Rizky. And Ms. Shani, are you there?
Yes, ma'am.
Yeah. Would you give us any comments?
Actually, we had an excellent session by Mr. Benny as well as Mrs. Sorry, I forgot. Chisato. Actually, Benny had covered almost all the area of Peri procedural consideration for neuro imaging was so excellent. And Chisato was also explaining the education preparation and the procedures being done by the Japanese nurse practitioner. It's also so much amazing. And what I could add is that, as Professor Maso was telling, the major difference between US nurse practitioner and Japanese nurse practitioner is that in US, I mean the doctor and the nurse practitioner is that the physicians have extensive educational preparation to take care of wider range of patient care population as well as disease conditions. But the nurse practitioners specialize in a specific area or a specialist in a specific kind of population. That's the main difference between nurse practitioner and a physician. And it was already answered by Professor Maso. Okay, that's all about my comments. Today we had an excellent presentation, so you can continue with your closing remarks. And we are running out of time. This is Ms. Chisato.
Thank you. Before the Ms. Okubo, let me give you the comment as a chief nurse practitioner. Today, the Ms. Chisato Fuseya presented about a Japanese nurse
nurse practitioners education, but it's still very quite new, only 10 years. Just started 10 years ago, and very small numbers of nurse practitioners are in Japan. But I hope it will be the national qualification sometime in also in a neurosurgery field has the subspecialty of the nurse practitioner. And now, Ms. Okubo, give us comments, please.
Oh, thank you. Thank you for every speakers. I can learn a lot of things. And as a nurse practitioner, in my opinion, the learning is very important. So the kind of this opportunity is very important, I think. So I'm very happy to meet yours. And if you want to learn about a nurse practitioner, please come here. Please come our hospital. We can join every learning. So please contact us. Thank you.
Okay, and now I'll hand it over to Dr. Haraguchi for closing remarks. Thank you.
Hato sensei, So,
closing remarks?
Yes.
Yes.
Can I speak?
Actually, I have to.
Can I speak, Dr. Kato?
Yeah, sure.
No.
Before that, can
Haraguchi sensei, you can make a closing remark. Maybe,
okay,
and also
okay.
Nagayama sensei, give us a few words, please.
Okay. Thank you very much for your very great time and great presentations. And this is the second time I took part in this conference, and every time it's very interesting. And so looking forward to see you again the next webinar. Thank you.
Prof. Kato would like to say something. Prof. Kato?
Before me, maybe Nagayama sensei.
Yeah. Thank you very much for it's so honored to join this wonderful conference and meeting, and just looking forward to join next time. And yeah, thank you very much.
So, okay, thank you very much for everyone. I'm so sorry because another webinar that I had, so maybe I missed the several talks. But I think all talks were so nice. And as a doctor, the neurosurgeon, so our department, we have two, the nurse practitioner, they work so hard. And without them, maybe we cannot have a smooth every day, I think. So I think at least maybe the nurse practitioner in Japan, maybe we need 10 times. Now is almost 800, the number of NP, so maybe we need more than 10,000, I think. And we need more, maybe, how to say, expand their power, and also maybe some mass communication, so TV or some other method. We can expand them, and of course there's some little different from US and Japan, of course, but it's okay. And also I need the maybe subspecialty, such as the two of them belong to the neurosurgery. Of course, they study not only the neurosurgery, but they can do everything. but they spend most of the time in with us, and they learn and they work together with us. I think in the future, maybe I think many subjects that as practitioner should we create in the future. So these kind of the webinar that we need more and more times, I think. Thank you very much for everyone, and also I want to thank you very much, Mrs. E, that he organized this wonderful young nurse webinar. Thank you very much. Shani, thanks so much.
Thank you, everybody. We will meet again the next webinar. Thanks. Bye-bye, everyone.
Thank you, Professor.
Thank you,
Bye.
Prof. Kato, Metrani.
Thank you.
Metrani.
So much.
Thank you.
Have a good
Before
chance.
everyone
Thank you
goes
very
off,
much.
Thank you.
hello.
Raja.
Yeah, Sensei.
はい、どうも、おや
I'd
すみな
like
さい。
to.
はい。
Yes, ma'am.
Good
Just
night.
I would like to say something because all our
Yes.
nursing colleagues are here. Because I'll just state that all the esteemed colleagues, please follow us on the social media web. We have our own LinkedIn page on LinkedIn and also on Twitter. We are on Facebook, and also this is being broadcasted on the ACNS webinar channel. The webinar channel is a huge channel with over 508 videos, more than 2,000 lectures. So I think it is a good resource. Please follow us up on Facebook, Twitter, LinkedIn, and also Instagram. That is all I want to say. Thank you.
Thank you very much, Raja.
Thank you. Thank you so much.
Thank you.
Thanks so much.
See
Okay.
you.
Thanks so much. See you
Okay,
next time.
bye-bye.
Thank you.
See you. Bye bye.
Bye.
See you, Prof.